Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and D.C. to keep you active and on the go.
Hello, welcome once again to the second part of our foot and ankle series for the Centers for Advanced Orthopaedics. This is On the Go with CAO, and our panel once again includes Dr. Steve Neufeld from North Virginia Foot and Ankle Center, Daniel Cuttica, who is his partner, and Gary Feldman, who's in Rockville, and myself, which I didn't introduce earlier, is Dr. Ricardo Cook. I'm also up in Maryland and do foot and ankle surgery. We're going to begin to discuss a little bit more of soft tissue injuries that seem to plague our patient population. They come in and probably see a little bit more of this than I do myself personally, than I do with some other real major bony issues, because people often walk uneven surfaces, get a tweak here, a tweak there. Unfortunately, we have the middle-aged guy who's picking up playing basketball, goes and feels a pop around his ankle and comes in with conditions such as a tendon tear or maybe a sprain. So here, what we'll do, we'll start off with Dr. Daniel Cuttica out of Northern Virginia. And what we'll do, we'll talk about, you want to start with Achilles?
Okay. Well, I think there's a wide range of Achilles tendon injuries. It could range from an acute injury like a tendon tear or rupture to more of a chronic injury like a Achilles tendonitis or overuse type injuries. In general, when we think about like an actual acute injury like an Achilles tendon rupture, typically you're going to see this in your what we call the weekend warrior athlete, who's kind of your middle-aged or 40s, early 50s athlete who really is kind of active occasionally. So typically, oftentimes a basketball player or cutting sports, jumping sports, who they tend to feel like a kick or like someone kicked them in the back of their leg.
And they swear up and down, someone hit me, man. Someone hit me from behind, man. They tackled me.
And they say, yes, they looked behind them and no one was there. And then they unfortunately weren't able to run, able to walk afterwards. So it's kind of a classic story. So kind of after they're kind of evaluated. We when we see them in the clinic or we see them in the office, we examine them. Typically, they'll have a lot of pain, a lot of bruising in the back of the leg. There's certain diagnostic tests or examination findings that we look at to determine if they have a torn Achilles tendon or not.
Okay, so basically, I don't know, but usually clinically you just can tell someone's Achilles tendon rupture. So here's a question that I get sometimes: how often do you get an MRI scan?
So very rarely, because I think a lot of the physical exam findings are very, very specific and very, very accurate. Also, we're fortunate enough at our center also to have a ultrasound machine in our office, and that tends to be a very good diagnostic and inexpensive modality to diagnose a complete rupture. So I tend to use ultrasound quite a bit in a lot of these cases.
It's incredible how often this injury is missed. Many times a patient goes to the emergency room after a basketball injury or a soccer injury, and they were diagnosed with a sprain by the emergency room doctor or the physician assistant, and in reality, they've actually torn their tendon completely, and it's missed all the time. It really is. So I think the community and patients need to understand that injuries could be more severe than initially thought, and that if things are not getting better after a day or two or a couple of days, they should probably get some evaluation by a professional foot and ankle specialist.
In a lot of these cases of an acute rupture, a lot of the symptoms start to gradually improve after a week or so. So I think a lot of patients will see, they say, don't notice, any real significant functional limitations until they start to get back into activities.
And they can't run.
So it can be a little deceiving. So I think absolutely it's important to have it.
Would you all agree, though? Would you all agree that definitely getting an ankle X-ray
Because the one thing you don't want to get burned with is the avulsion fracture. I mean, the avulsion of the Achilles tendon from the calcaneal tuberosity.
Absolutely. We take
Yeah,
X-rays on all
yeah.
suspected tears because sometimes I think what you're referring to is when the Achilles tendon pulls or ruptures or tears at the bone,
Yeah.
pulls a piece of bone. And yeah, I'm a big believer in that. But I also agree that it is distinctly a clinical diagnosis. Ultrasound's great, but it's rare that we order MRIs in our
Yeah.
clinic for that.
Now, there's been a lot of controversy over time regarding Achilles tendons repair versus not repair, the outcomes of repair versus a non-operative repair, augmentation. I'll start here with Gary, then we'll go to Steve, then we'll come back to you, Dan, how you guys feel about it. And,
Well, my experience it is typically I find better results personally with surgical repair, but it also is going to depend on the patient. But in my hands, I think most of the people that I'm seeing are typically men, typically in the range of 35 to 55 to 60. You know, and in that population, most of these people are doing activities. In fact, we talk about the sedentary individual who gets up and goes to play sports for the first time and ruptures, but there's also a subset in my practice that I see quite often of people who are active, but they've been dealing with some Achilles pain for some time and they maintain activity and then they pop. So I try to get these people back to athletic activity as quickly as possible. And in my hands, that has typically been surgical repair, not to say that non-operative repair is not an option in certain patients.
I agree that the goal is to get somebody back functioning, playing sports. Again, as I mentioned earlier, people don't want to sit around. They expect to be active. They want to play pickleball. They want to play golf again. The literature changes every 7, 8, 10 years.
Yeah.
It goes around and around and around. And I think at this point, it's understood that in the right hands, in the right patients, conservative non-operative care works as well as surgical repair. However, it is difficult to do that because we call it functional rehab. So if that person can be plugged into the right physical therapist, to the right doctor who can guide them on a very functional rehab in a boot, maintaining strict protocols on rehabbing that tendon, then you could actually do okay with functional rehab. The reality is that if you want to get somebody up faster, quicker, playing sports, for the majority of these weekend warrior athletes that want to get up and running, surgery tends to be the quickest. There's nothing wrong with conservative care, but it has to be a functional rehab. You can't put somebody in a cast or a boot and say, I'll see you back in 6 months, you'll be fine. I think that's old thinking. I think if you're going to manage it conservatively, it has to be actively functional rehab, which needs a lot of guidance and a lot of training.
a lot of education.
A lot of education, exactly.
I would agree absolutely with that. I think a lot of it is very patient specific, first of all. I also think you have to have just a good conversation with the patient because not everyone has the same goals after their injury. If it's someone who wants to maintain a very, very high level of athletic activity, I think I will typically steer them more towards surgical treatment. I also think you do get a little bit more of a predictive outcome with the surgical treatment, and a lot of the risks that were previously described with surgery were with larger open incisions,
Let's get into that.
things like that. Where I think now there are newer techniques again where you can do things through much smaller incisions. So the risk of wound problems, infections, although still there, are much lower. I also think that you get a very, very good end-to-end tendon repair with the actual surgical repair. So you have a little bit more control with that, and I think most of the time they're going to have a little bit of a better outcome overall.
I definitely agree. I think it's hard to get that end-to-end repair with conservative because you have to put a little bit of plantar flexion, and then you got to gradually break them down. It's not as control you're hoping, but you just don't get that close end-to-end. And then with the newer techniques, like they say it's percutaneous, but I think it's a little bit more mini incision, incisions, not huge incision, and the percutaneous techniques bringing it together. And I find people are very satisfied with that very small incision. There's less chance of infection going on, and they actually turn around pretty quick. And one particular question I know that pops up when I go to conferences and stuff like that is the tightness of the repair. Do you find that the tightness of the repair really matters, or do you find that they stretch out over time?
think they stretch out.
They stretched out,
Really
yeah.
do.
Mhm.
Absolutely.
Maybe they stretch out. Okay, so that sort of like covers Achilles tendon. Now there is another portion of Achilles tendonitis, which is more insertional. That's the chronic type, not the part where you have that leg injury or the sudden acute pop, or the one where it inserts directly into the bone, which can be very problematic. And that patient population tends not to be young, tends to be a little bit older, what, 40s, we say mid 40s, 50s and up and stuff like that. And also Achilles tendon ruptures, I've not seen one Achilles tendon rupture under the age of 20. I may see an ACL, but I have not seen Achilles tendon rupture under the age of 20.
Very rarely.
That's very rare. But this insertional Achilles tendinosis, that can be a problem. I'll start with you, Dan. And then how would you understand?
Yeah, so typically they come in, they present with pain over the back of their heel, and that's right at the spot where the Achilles tendon attaches. A lot of times they have pain getting up in the morning at the back of the heel, pain with stairs, going up and down stairs, usually with activity. Essentially, this is a little bit more of a chronic problem, so related to something that we'll call tendinosis. So it's little micro tears, wear and tear at the Achilles as it attaches, and it can be a lot more difficult to treat than other forms of tendinitis or tendon problems because of the chronic nature of this. We will always start with a good history, good physical exam. How does this affect their activity level? How does this affect their daily life? Usually there is an X-ray that's warranted. A lot of these patients have small amount of calcification or spurring in the back of the heel that can go along with the tendinosis too.
So typically, what would you prescribe? What would you prescribe for them? How to get them over conservative?
So, insertional Achilles tendon or pump bumps or heel pain, those terms have been used a lot. Typically come from patients with very tight calf muscles. If you have a very tight calf muscle, it pulls on the Achilles over the years. It's pulling on the bone insertion. You get little micro tears, and that forms these spurs. So if you can get them more flexible again, with physical therapy, with stretching, with braces and things like that, many people get better. We also use a lot of new technologies these days. So we have things like shockwave therapies. We have laser therapy. There's all these things that we can do short of surgery to try to get that tendon to heal. There's no way to make that bump to go away without surgery. But many people can live with a bump on the back of their heel and not have pain. The key is just to figure out how to get them through that. And it's usually through a conservative stretching, rehab.
Yeah, that chronic inflammation, I think, sends off the chemotactic factors that elucidate all those. I won't mention all this stuff, but it eventually comes in there and causes all that pain and all that response, and the people are just miserable. Gary, so surgical technique and as far as getting rid of that bump, that pump bump, or that spur back there, how do you approach it? Do you go directly on it, or do you go by the side? Do you find one way is better than the other, or is just getting rid of it?
It's one of the few procedures that I always have touted for many decades myself, that is fairly guaranteed that patients are going to do spectacular after surgery. Because by the time you get to surgery, these are patients who have gone through physical therapy. We've tried different techniques, we've rested, we've used medicines, they're not better. So again, it goes back to what I always use as the phrase in my practice, quality of life. Surgical technique for this is very simple. I do use an incision on the back of the heel, sort of not in the midline, but kind of off to the side. It allows me to reflect the Achilles off the bone, clean up and repair the Achilles and reattach it. And there are some very strong techniques that we have available, or strong equipment in surgery that we use to re-anchor the Achilles tendon back to the heel bone. And it's really strong, so strong that I get my patients weight bearing in a very short period of time, within 2 weeks after surgery, and rehabilitating very quickly.
I would even add to that now we're moving even more towards minimally invasive, where we can make a very, very small incision and use a scope, like a laparoscope or a knee scope or an ankle scope or a toe scope. We can actually put a scope back there with a burr and shave down the back of the heel bone. And that works.
How do you position?
Usually prone. I'll have them lie down with their foot at the end of the bed.
Okay.
And two little tiny incisions on each side of the back of the heel. And we use a burr with an x-ray machine and we feel it and we see it and we just clean out the burr. Many times if the Achilles is tight, we'll actually lengthen the Achilles at the same time. But those patients also do very well without the big incision. So depending on the patient, depending on the condition, that's an option. But just like minimally invasive foot surgery in general, we've been talking about all day, all this requires a lot of training. All it requires a professional who knows what they're doing. Lots of practice, but it is tried and true, and it really works very well with quicker results.
So moving from Achilles tendinosis, we're talking about heel pain, we're getting to a very common problem that plagues people when they come in. They're talking about, hey, Doc, I've had this heel pain. I don't know where it came from. I didn't fall. I mean, it just drives me nuts. I get up in the morning, it bothers me. I drive in my car, I get out of my car, I start to take the first steps. It's just annoying. I can't put on the shoes. I dread getting up to walk because I know this pain is coming. And that would be probably plantar fasciitis and stuff like that, which is a collection of stuff like this. It can't be just isolated, but it would be multiple things. But that is a big problem in foot and ankle. So I'll start here with you, Steve.
Yeah. I think plantar fasciitis it plagues, it seems like everybody. I think everyone at some point in their life wakes up with heel pain. I personally had it myself.
I had it too.
And similar to Achilles tendonitis, it comes from tight calf muscles. I think women who wear high heels, some men who wear high heels, men tend to get stiff as we get a little bit older. We don't stretch very much. If you have a tight calf and a tight Achilles and you have a tight plantar fascia, something is going to give. And many times it's the plantar fascia. And that's at the bottom of the heel. It's typically weight bearing, like you said. When you step down in the morning, you take that first step. So the treatment of that is almost always conservative. If you can get that leg, that Achilles, that plantar fascia flexible again, it usually makes people feel better. So we do therapy and we do night splints to get them stretched, and we teach them exercises in the office, and we do orthotics to kind of cushion the heel and to give them some support. But most of the time it gets better. There's a lot of new technology out there that really helps people heal quicker and safer. But the mainstay of this is really teaching patients, educating them on flexibility and ways to change their activities to get it better.
When does the point come across the panel where you guys say, okay, we've done these things, so when do we move on to surgical intervention, and what do we tell the patients to expect after they have the surgery?
So I think it's important to know that the non-surgical treatment for plantar fasciitis is usually very, very successful, probably in about 90-95% of patients. So it's a very, very small subset of patients who don't improve. So typically plantar fasciitis gets better, but it gets better slowly. So we usually try to have people treat them non-operatively for usually up to 6 months with these various treatments. So physical therapy, like Steve, all the treatments that Steve mentioned. If we get to a point where we've really, really worked on this for about 6 months, sometimes up to a year in some people, but that's the time to consider potentially a surgical type treatment.
Or someone comes into you and say, I've had this for 2 years, and they give you a history. I've done these treatments. I've done these treatments, stuff like that. I mean, I still try to do a little conservative with them,
Right?
just to make sure, But essentially, if they're really that bad, and then do you guys order a MRI scan before you do any? If you were to do surgery, just to make sure that it is what you think it is.
Typically, yes, because there can be some things that mimic plantar fasciitis that, when in fact it's not truly plantar fasciitis. So I think that's important before undertaking any sort of surgical treatment.
Right. There are things like spine problems. You could have a herniated disc that's pushing on a nerve that presents with heel pain. And I see that every so often as well. You can see somebody with something called tarsal tunnel syndrome. It's like carpal tunnel syndrome, where the nerve is getting squeezed at the foot, and that causes heel pain. So I think MRI is a reasonable approach for certain people before you're going to do surgery. And if they get to the point they need surgery, it's usually somehow releasing that disease, that torn plantar fascia, getting it to heal somehow. And there's different ways of doing that, small incisions, big incisions, but it's kind of the same idea. And many times if it's associated with a tight Achilles, we're going to lengthen that Achilles tendon as well.
So I think the common theme you're hearing within the first session and the second session is that when you come in,
there's a certain expectation. Of course, everybody wants to get better, but there's a process of assessing the patient and understanding who the patient is and what the patient wants and what techniques are available and what they can do for you and what the history that we have in medicine says how we can help you before proceeding with an invasive surgical procedure. It sounds like there are some issues that do need immediate surgical intervention, some fractures and stuff like that, but a lot of the things that we do can be treated conservatively. You just have to be patient with it. Now, I think that's a general motif that you'll find with foot and ankle issues. The one thing we did talk about in our last section was bunion deformities. Bunion deformities do not reverse themselves. They do not get better. That's one thing I've seen. They just get worse over time. They just get worse over time. So probably one of the last sections we'll get to is ankle sprains, which by far probably is one of the more common emergency room visits and doctor visits that you guys get. And this takes the whole gamut. This is from young all the way up to old with ankle sprains and stuff like that. Who wants to start off with that one?
Typically, your most common, when you think of a sprain, the most common injury is, the foot will kind of turn or roll outwards. And when that happens, essentially, if it's severe enough, the main ligaments on the outer part of the ankle are stretched or torn to some degree. And that's really what a sprain is you're stretching, you're tearing ligaments, and it varies based on the severity. Most ankle sprains typically get better with non-surgical treatment. So even if you had what we call a grade 3 ankle sprain where the ligaments are completely torn, there's a very, very good chance that they're going to improve with a period of immobilization followed by aggressive rehab physical therapy. So most of the time we initially treat that with the period of what we call RICE, which is rest and ice and elevation and compression. Sometimes that involves a boot, like a walking boot for a short period of time. Sometimes that involves a brace. Once the initial pain, the initial swelling has improved and you're able to comfortably put pressure weight on that foot, usually you work with the physical therapist to really start rehabbing the ankle. And the majority of patients will be better. And I think we usually say about 80% of the time you're not going to have any recurrent issues. Mm-hmm. There's a small subset of patients who do, and that is, those are the cases where the ligaments heal, but they sometimes heal very loose or lax, and they have kind of what we call chronic instability, where the ankle kind of just feels weak or wants to give out or roll frequently.
Pretty much what you
Yeah, I agree with everything Dan said. I think a big misconception with ankle sprains, people come in and they're confused as to it's been 2 weeks, why is it not better? I think there are some, you get that too. I think there's some limited sprains that get better quickly. But that tends to be the minority. I see a lot of people come in with, they still have the big swollen, bruised ankle. They went to urgent care or ER. They might have been given like an air brace, something simple, and they don't know why they're still having symptoms. Mm-hmm. If anybody has, and we all tend to grade these in different ways, but for the most part, mild to moderate to severe. And the moderate to severe injuries are the ones that I do exactly what you said, Dan. I immobilize them in the beginning. I think that early immobilization, controlling swelling, controlling mobility can be a key to limiting future instability. And then most of my patients, they do either do their own therapy or they go to therapy. They're supported with braces during recovery and into a return to activity.
Yeah, I agree. And I'm also shocked how often somebody comes in with an MRI with an ankle sprain.
This is true.
I don't think that a routine ankle injury, rolled ankle, needs an MRI. And unfortunately, MRIs can be misleading because they will tell the patient and the doctor that their ligaments are torn. And somebody comes and says, "Doc, look, my ligament is torn. I need you to fix it." The reality is that humans can heal some things well. We can heal ligaments, we can heal bones, we can heal skin, as long as they're treated properly. There's some things we can't heal, but we can heal ligaments. While bones heal quicker than ligaments could take months and months to heal, they usually heal. So if they're treated appropriately, they don't need surgery. And I agree with what the other panelists are saying, that conservative treatment is the way to go for most ankle sprains.
I think this is the general consensus across the world. The mega studies throughout Europe, here, United States, and stuff like that all across the world all agree that most even people who have unstable ankle sprains, you can treat them conservatively and hopefully they return back. Now, there is a subset that you did allude to, Dan, is the amateur athlete, maybe professional, semi-professional, professional athlete who really wants to get back, and they say, okay, you're not going to operate on me initially in the beginning. I get that. I'm okay with that. What are my chances of returning back to my sport and being able to perform at the level that I want to perform with non-operative care?
I would say that, if they are an elite athlete performing at a higher level, at a very, very high level, I still think there's a chance. Is it as high as, you returning to function in your weekend warrior recreational athlete? Probably not if they have an unstable or a loose ankle. I would still recommend an initial trial of rehab because the things that I think physical therapists are doing are these days are pretty amazing. Plus, there's various forms of bracing, athletic type braces that do not limit them functionally, where they can still have some level of stability and still compete at a high level.
How much time would you give people? I mean, obviously, I think it's very rare that anybody acutely in less than 2 weeks is going to operate on an ankle sprain, unless it was associated with a fracture. That's a totally different animal. But just an isolated lateral ligament sprain, they've gone to conservative treatment. What's your timeline where you start getting a little bit curious? And they have pain. Let's say they have pain, not just instability, but pain as well. Where you say, okay, things are not proceeding as I would hope they would proceed, and I think we need to do more.
Well, I think a torn ligament after the initial healing should not be painful. So I get worried at around 2 to 3 months if they're not feeling better. And I start to think maybe something else is going on. Maybe there was some cartilage damage. Maybe there's some scar tissue that's built up in the ankle. At that point, I would consider getting an MRI to see if we're missing something.
Yes.
And most of the time, if they're still hurting by 2 to 3 months and not getting better, there's usually something else going on. And that would typically warrant surgery or thinking about an alternative approach.
After the first visit, when we talk about the protocol, I'll even say exactly that. I'll say, look, in the next couple months, if there's still a lot of pain, swelling, limited ability to get back to activity, then we might want to do an MRI to evaluate lateral tendons, cartilage, and things like that.
Yeah, that's what I tell them too as well.
Exactly.
I tell them too as well. And then there is a differential diagnosis in there because sometimes you can have these ankle sprains and one thing they can come in, and I'm pretty sure every one of us seen it. Oh, doc, it feels better, but all of a sudden I got this popping around the side of my bone there and stuff like that. Or they may present initially with that type of sprain. That's a different diagnosis, and that requires a little bit more of immediate attention. Someone setting peroneal tendons.
Yeah. So if you're referring to the tendon popping out, so the tendons on the outside of the ankle, under the ankle bone, can what we call sublux or pop out after injury, and that indicates an injury to a ligament that holds those tendons in place. If that is present, that's typically something that requires surgical repair. And I do see that occasionally after really bad ankle injuries. More commonly in my practice, I'll see that as a chronic problem. But I agree with you. That would be more of a concern for something that needs to be repaired more urgently.
That's the one case I think where people have to jump on that because that can turn into a tendon rupture or something like that. What we didn't talk about is the newer techniques of surgical repair, and that including also with the soft tissue with Achilles tendon, using augments and autografts and stuff like that. Anything you guys are using now currently on the market? But we have the minimally invasive bunion. There's some things on the market that we can use to help augment our repairs.
Yeah, I'll jump on that. The technology these days is really amazing, and we are able to use synthetic manufactured ligaments if need be. So many times, if a patient has long-standing instability and the ligament never healed in the correct position, and there's really not much to fix, nowadays we can use artificial ligaments that behave and work just as well as the native or the person's ligaments. We can use tendon that have been donated. So there's lots of ways that we can reconstruct previously difficult reconstructions. Now we can fix those people. It's pretty amazing what's out there.
But would you say that's probably not the majority? That's definitely the few and far in between, not the majority. Because most of them we do our typical procedure, which is the modified prostrum, whatever it is, and prostrum.
I think in some cases, especially someone who's looking for a quicker recovery, some of these kind of or the synthetic ligament type of treatment do allow a little bit of a quicker rehab because you can be a little bit more aggressive with the rehab. So in someone who has kind of long-standing instability, sometimes the tissue is kind of wimpy or not great. Exactly. So a lot of times in those cases, you immobilize these people in a boot and a cast up to 4 to 6 weeks, where because you have to wait for their tissue to heal. Well, when you use a synthetic ligament, you can be a little bit more aggressive because the ligament essentially will protect your repair.
And you use a soft tissue. Do you use a biologic, the lentiginous tissue along with the synthetic tissue to reinforce it, or just you rely?
No, I just use it's a synthetic graft that by itself.
Okay.
And mainly because its properties mimic natural ligaments. Yes.
No, I agree. I think where we are today is dramatically different than our predecessors and our instructors were, years ago. We've really come a long way in rehabbing and reconstructing and getting people back on their feet much quicker, and better quality of lives for many, many more years than we were before.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.